Good evening, and thank you for joining us here on blackdoctor.org. I am Ellis Dean, the digital programming and production manager at blackdoctor.org. And so, for all of your health and wellness, culturally relevant health and wellness news, please check us out at blackdoctor.org. I am excited, really excited to have this conversation tonight because it's something we rarely talk about. If you did not know, May is Healthy Vision Month. And so, yes, there's a lot of months out there. There's a lot of days and weeks and things out there. And Susan G. Komen is not the only month that's out there. I know we gets dominated with the pink everywhere, but this is Healthy Vision Month. And we are excited to kick off Healthy Vision Month with this series. So we're going to do a 6-part series on eye health, starting here in Healthy Vision Month. And this is all about diabetic retinopathy. And so who better to have with us than our expert, and that is Dr. Joseph, aka as you see Joe Coney here with us. He is an ophthalmologist, and I learned just the other day there's a difference between an ophthalmologist and an optometrist, and so we could talk about that too. We'll talk about that too. If you don't know the difference, we can let you know that what that difference is. But he is an ophthalmologist. He's a retina specialist, and he is also an eye surgeon, which you know how delicate those hands have to be in order to do surgery on the eyes. So we are really excited to have him here as part of this series, and we're going to kick this one off really kind of talking about your risk of diabetic eye disease. And so we know diabetes is rampant and disproportionately impacts our community and our community as Black people. And so, but we just think about it in terms of the sugar, whatever we want to call it, but we don't understand that diabetes has far-reaching implications on our overall health in terms of unnecessary amputations and PAD. We've got diabetic neuropathy that can happen. And this one in particular is about our eyes because diabetic retinopathy is a big factor as why people go blind. And it can make you go blind if it's not taken care of. So I know you didn't sign on to hear me yap on, so I'm going to say, welcome, Dr. Coney. How are you doing this evening?
Ellis, I'm fired up, man. Thanks for having me. Looking forward to the discussion tonight.
So I touched on it a little bit, but I just want to have our viewers know, as a refresher, could you kind of just talk about diabetes and its impact on our body as a whole, and then we'll move into our impact on the eyes.
So Ellis, thanks, man. I'm going to keep this as simple as possible, okay? Diabetes essentially is when your blood sugars are just too high. And we get into trouble when the blood sugars are too high over periods of time, then people have problems. And it doesn't just affect the eyes. When you have diabetes, it affects really not just the blood vessels, but the nerves. So people can have, heart disease, they can have kidney problems, they can have problems with their toes and their feet. For what I do, it affects the eye. So it always affects the N-terminal organs the most. So that's why people have, peripheral neuropathy, the numbness and tingling starts. They affect their kidneys. That's nephropathy. The heart, the eyes, the brain. When it comes to the eyes, diabetes at the earliest stages, people don't have any vision loss, but they have changes in the blood vessels before any vision loss ever occurs. And these blood vessel changes, it changes over time, and not just the sugar control affects the eyes, but the duration of the disease. So over time, with elevated blood sugars, you have damage that's going on to your small vessels throughout your whole body, as well as your nerve tissue.
So we've got the damage with the blood sugar being too high, and that is from insulin, right? So insulin, I forget the name of the gland. It's a pituitary gland that produces insulin. Which one is the gland?
The pancreas.
Pancreas. I'm sorry. Pancreas.
It's all good.
Okay, all right. I've learned it just like so. Pancreas produces insulin, and then that insulin becomes you get too much blood sugar and basically become diabetic. And there's a number that our blood sugar reaches over, and there's two types. There's blood sugar number, which is it ranges from over 125, and then there's your A1C. That there's a level that pushes you over into the diabetic realm, and so then it becomes problematic. And you can get on medications. And as what Dr. Coney is saying, it can start impacting those smaller blood vessels around the body. You get the tingling, you get the numbness, you get some blockage. That's how we get amputations when that blockage starts happening, because you don't feel it, because you get that numbness. You're like, I don't feel it. And then next thing you know, we can lose a limb potentially. So All right. So in layman's terms, so now we're talking about the eyes. We're going to focus on what your specialty are. All right. So I had to learn as I was, doing my research for this particular broadcast. I was learning about diabetic retinopathy, and I had to learn how to spell it for one thing. But the other thing is, what is diabetic retinopathy in layman's terms, so people can really kind of get a visual, for like, pun intended, of what it is.
So diabetic retinopathy is a complication of your diabetes that affects the retina surface in the eye. And the retina is really the lining behind the eye. How I like to define the retina. So if you look at a camera, we're talking about these old cameras. The young people don't know what an old camera is. We're talking about the cameras that actually have the film. Your retina is like the film in your camera. Your cornea and your lens is kind of like, the lens in the camera. You can always change that. But when it comes, so if the film in the camera has been damaged from like water, sunlight, or exposure, you don't get a good image. If your retina has been damaged by those same things, you don't get a good image. So it's the lining behind the eye which allows us to see. We have some things called photoreceptors. These photoreceptors is kind of like the key to the brain. And when those get damaged from abnormal blood vessels and water in the eye, which we call diabetic macular edema, which is the leading cause of blindness, believe it or not, then people can lose their vision. I think the most important thing, if I can just interject here,
Mm-hmm.
and go right to the crux of the problem, because I know who your audience is. I think the biggest thing here is that in the early forms of diabetic retinopathy, typically people have no symptoms. And as the disease progresses, these blood vessels, they continue to grow, they continue to leak, fluid increases, and then the vision starts to decrease later. Things become, splotchy or kind of washed out. Things become distorted, and in the later stages, they develop these new blood vessels, they bleed in the eye, they see floaters, and people can even get scar tissue in the eyes where they can go completely, and they can lose their vision. So I think the most important thing that people don't know is that at the time you're diagnosed with diabetes, you should be getting an exam, because you don't know how long you've had diabetes before you were diagnosed. And so the ADA has recommended that everyone gets an annual exam, including at the time of diagnosis. And so I want to leave that message behind, that as soon as you're diagnosed, go get your eyes checked. We need to find a way that we put eyes as a priority in our life. People are good about checking their feet and going to get their heart checked. But typically, if something's not bothering you, you don't get it checked.
And I had this thought the other day. It was interesting, like how many people don't really go see an ophthalmologist, right? We think about seeing our primary care physician, and we don't think about seeing an ophthalmologist until there's a problem, right? And then it might be a little too late. And as you're talking about, it sounds like what you're saying is there could be a problem way later, like it could be going on, and your body is trying to adjust by developing, other vessels, but over time, by the time they say, "Oh man, I'm really having a problem with my vision," they come see you, and you're like, "Oh wow, how long has this been going on?" And you can tell how long. And then I also,
Ellis, the great thing about what I do, and other people can't do it, is that I can see changes before it affects people. People can't look at your heart and see that you have a blockage. People can't look at your kidneys and know that you have protein in your kidneys. You can't look at your feet and know that your circulation is going bad. When that happens, you already get numbness and tingling. Your kidneys are growing bad. You have chest pain. But in diabetes, because it's one of the few organs that we can look at just with an eye exam, we dilate the pupil, we put a couple of drops in. There's no pain associated with it. I can look in the eye and take a look into the journey that someone is going on with their diabetes. And if we are able to detect diabetes, our medicines are good enough where we can delay the vision loss. In this day and age, there's no reason why anyone needs to lose vision from diabetes. And unfortunately, between the ages of 20 and 74, diabetes is still the leading cause of blindness in the United States. And to answer your first question about screening, 50% of individuals do not get screened when they have diabetes. And this is even worse when it comes to underserved populations.
Wow. Okay. So if you're just joining us, we are talking to Dr. Joseph Coney. He is an ophthalmologist, and we are discussing diabetic eye disease, and in particular, specifically diabetic retinopathy. We want to thank our partners at Genentech for helping us put this on. May, as you know, if you didn't know, is Healthy Vision Month. And so we are kicking off this 6-part series here in the month of May of Healthy Vision. So, one of the things, like with many conditions, there's stages, right? So like there's stages of cancer. We always hear about, oh, I got stage this, stage that. Are there stages in diabetic retinopathy, or is it just you have it or you don't?
No, there are stages, and I think that's really important for the clinician standpoint. But the stages in diabetes, typically, I'm gonna make it simple. We have something called proliferative and non-proliferative. Proliferative just means there's blood vessels. Non-proliferative means there's no blood vessels. So those are the terms that you may hear your doctor talking about. Now, within non-proliferative, you have a few main stages: mild, moderate, and severe. And the reason why those are important because we try to look in the eye, we see how many hemorrhages you have and these cotton wool spots. These are just changes that we see in the back of the eye. And based on these changes that we see, we know when a patient should follow up. The most important thing for me, the most important prognostic factor that I have in my patients is my staging, because that staging tells me what the probability is that the person may lose vision over a period of time. And I know that when you're at severe non-proliferative disease, I need to follow you very closely because your risk of severe vision loss could be as high as 50% over the next 3 years. And that's the reason why staging is important.
So is the condition of diabetic retinopathy, is it an inevitable conclusion of diabetes, or do some conditions have to be met in order to get diagnosed with diabetic retinopathy?
Most people in about 20 years will have some type of diabetic retinopathy, but not all people that have diabetic retinopathy is actually going to lose vision. I think that's the more important thing. A third of the people with diabetes, about 25, 30%, will actually develop diabetic retinopathy. And then half of those people will develop more sight-threatening problems, which actually would need more therapy. People think because you have diabetes, it's a death sentence. I'm going to get a heart problem. I'm going to have kidney problems. Let me tell you, I have people that have lived with diabetes for 50 to 75 years that have very little retinopathy. I think the key is tight control. You mentioned it earlier. You mentioned something point earlier about glycemic control. The most important thing you can do is check your hemoglobin A1C. Your hemoglobin A1C is your average sugar over about 3 months. Normal, that number is between 4 to 6. I typically recommend my patients be less than 7. As long as you keep that number less than 7, then most times we can protect your body. But oftentimes, and particularly in our African American community, the A1C is greater than 10, 12, 13, even 16 I've seen. And those people are the highest risk for developing retinopathy. The last thing I'll say about this group of people when it comes to Blacks and African Americans is that not only is your sugar control is important, but your blood pressure, your cholesterol, your diet, your exercise. So the things I try to leave my patients in terms of education is your ABCDs. A1C less than 7, your blood pressure less than 140/80. Watch your cholesterol, increase your activity, and watch your diet. And the smoking, obviously, we know can affect your blood vessels as well.
Absolutely. I like that. ABCs. Run that back for people so they can get the ABC. So you said A1C,
your
blood pressure,
A1C, blood pressure, cholesterol, diet, exercise.
ABCDE. Very, very simple. I'm gonna put that up there. So y'all make sure y'all remember that, because that's something that's really easy to know, especially for diabetics. And so did we talk about, I think, you've been mentioning some statistics. And you said about over about half of the people with diabetes will develop some stage of retinopathy?
Well, about 90% we develop some form of retinopathy. And what I tell my patients that, it's okay to have problems as long as your problems don't control your life. And the majority of people actually do not develop retinopathy that is sight-threatening. So the people that develop sight-threatening problems is only, half, close to half of the people that develop the disease itself. But 30% taking all comers are the ones that develop, a form of retinopathy that we really have to observe closely. But the problem is that 2 to 3%, disproportionately retinopathy affects, Blacks and African American 2 to 3% more, more common than our Caucasian counterparts. And so because we don't know who is at the highest risk, I think everyone needs to have that annual exam so we can correctly stage it, follow it, treat it, and preserve vision.
Here's an interesting question from the comment section. Does long-term COVID increase this? Right. And so I know we've been talking about COVID and long COVID in particular, and there's still, it's kind of hard with the new disease to be able to project out, but we're starting seeing some signs in terms of impact and long COVID. So do you think that long COVID have some impact on diabetes and diabetic retinopathy?
Dean, I've seen this all across the board. So one thing about, because I'm a retina surgeon, I treat people frequently for a diabetic retinopathy, and the treatment is really certain injections that we put in the eye that we can slow down the disease. And if you fall off your regimen, then your retinopathy can worsen. Because of COVID, people didn't come in during a scheduled appointment, and we've seen a lot of people progress to the point where we're still trying to get them back to where they were before. So that's number one. Number two, I've seen a lot of new diabetics that was diagnosed during COVID. Unfortunately, when people got really, really sick and they needed to be on those ventilators, part of that therapy they were on was high dose steroids. And then steroids kind of, threw their body off, out for a whack. I mean, they needed the steroids to actually live. It's kind of like, when we had the small preemies that developed retinopathy of prematurity, we know that high dose steroids actually worsen the conditions in the eyes. Oxygen content worsen the disease in the eyes, right? I'm going to say oxygen. So it's kind of like the same concept. Either the oxygen content or the steroids really put them in full-blown diabetes, and now they have retinopathy. I still think it's chronic problems is still hard for you to say because we're only 2 years into this pandemic, and where people are the next 5 years, we don't really know. It does take some time to develop retinopathy. I think those people that develop retinopathy, they could have been pre-diabetic. There's a lot of people in this country that are pre-diabetic, and I tell my family members, if you're pre-diabetic, I still want you to go get a baseline exam. And I think that's the most important messaging that we can tell our patients, because early diagnosis, again, means early treatment, means delayed, in vision loss. So I think some of this is still, we really don't know, but I have seen a lot. The last thing I'll say about COVID is that because it's an inflammatory component, diabetes also has an inflammatory component as well. And when you have diabetes chronically, that your body changes. And it's particularly in the eyes. I mean, we have different medications that go in the eyes. Some of them also treat inflammation in the eyes. And I think that's another reason why their diabetic retinopathy worsened during the time that they had COVID-19.
Oh, wow. Okay. So there's a lot to unpack. It's a lot to unpack there. So I think number one is if you haven't gotten vaccinated, we encourage you to go get vaccinated or get boosted so you can kind of lower the impact of COVID. Because we've heard there's been some reports of people developing diabetes as a result of getting COVID. And so if in pre-diabetic, so that there's a term, right? Because I've heard as many as 88 million people are pre-diabetic. Help our audience understand, what does that mean, being pre-diabetic?
Some of us are predisposed just because of genetics. Your mom had diabetes, your dad had diabetes. A lot of us are predisposed just because of our lifestyle. There's a direct correlation to like hip height and hip waist ratio. When we start having that adipose tissue and that fat tissue around the abdomen, that also increases your risk for diabetes. Having blood pressure, smoking. But the sedentary lifestyle and the fatty foods definitely, I think, plays a significant role in developing diabetes. And unfortunately, it's much more common in our African American and Black population. So, I think that, now the weather's breaking, we all need to be getting our steps in. If you haven't worked out in a while, I tell people it's not a bad thing to talk to your doctor to figure out how fast you can go for it. But we all need to be having healthier lifestyles.
Absolutely. And I think, to add to that, because, we talk about that a lot here, is I think people view, when you hear the word exercise, I think people view it as this really kind of, I've got to get dressed, I've got to go to the gym, I've got to do all this stuff. You can exercise by walking. If you have stairs in your home, you can exercise by walking up down the stairs. You can exercise by cleaning your house by doing it at a faster pace, right? So get your heart rate up, do it at a higher rate. So really what we're talking about is elevating the heart rate for a period of time every single day. So we've got to rethink how and reshape how we think about exercise, and not in just, I got to put on workout clothes, go sweat and go, sweat in the gym for an hour and a half. No, it's really there's many ways that we can exercise and get our daily requirement of exercise without having to visit a gym.
Dean, listen, even if you have retinopathy, nephropathy, numbness is cleaning your feet, and you have a hard time walking, you can get in a pool. It will help, make you a little bit lighter, and just walk the pool. Any little bit of activity will actually help. So there are things that you can modify yourself just to kind of, do those things that you were talking about in terms of raising your blood pressure in order to keep yourself fit.
Yeah. So, okay. So here's the $50 million question. Can diabetes be reversed? Because we've heard some folks think that it can be. Can diabetes be reversed?
So that's a complicated question. I will tell you this, people have undergone certain procedures, pancreas transplants, and those are, that's what we were talking pancreas transplants. Those individuals are able to get off their medicines. I think they should be watched extremely closely. The problem is that the damage that has been done to their kidneys, their heart, their eyes, that doesn't stop. And people think just because I'm not on medicines anymore, I'm cured of everything. But damage to those smaller organs, they're permanent. Once you get nephropathy, those nerves aren't coming back. Once you're on dialysis, you're staying on dialysis. Once you have retinopathy in the eye, that's what you're always going to have. But can a person get off their medications? Absolutely. There are also some people that get off their medications just with changing their lifestyle, loss of weight. I've seen people that have dropped their BMI by 10, 15, 20%, that their doctors are watching them, because their sugars are dropping on their medications. They have taken them off their medications. So just dropping the weight alone would decreases your body demand, so you don't require as much insulin. And so people have been able to be monitored. My recommendation that is just make sure you continue to follow up with your doctor. Make sure that they're still checking your A1C level. Make sure you're still keeping your blood pressure, and your cholesterol in check. But I have seen those things, and again, I think for this kind of talk, those conversations should be designed around the doctor. But I have seen people come off their medicines.
Okay, so for those that think again, I saw somebody put in the comments, they said yes. I will say, so what we're saying is this: work with your doctor. Number one, work with your primary care physician. Number two, make sure that you're maintaining your regimen. So even if your doctor takes you off of your medication per se, that means you still should be checking your blood sugar, checking your A1C, checking your blood sugar level. You still should be doing your exercise. You still should be eating healthy, because all of those things helped you get to the point where he could take you off the medication. Don't stop those things just because the medication has stopped, because the likelihood of you getting back on is going to increase significantly if you stop those behaviors that got you off the medication. So just kind of a one, but I want to address the elephant in the room, because I know a lot. I've heard that, seen a lot of that. So I want to make sure that we address that and move on. So I see this comment here from my man Roy. I was on metformin. A1C was like 14, lost 45 pounds, took me off my meds, and my A1C is stable 6 for the past 4 months. Great. Excellent job. Roy's a good friend of mine, so I'm glad to see you doing well there, Roy. All right. So are there other conditions? Because I know one of the things that, when my wife was having our children, the doctors always monitor women when they get pregnant about gestational diabetes. Are there conditions like gestational diabetes that could impact the eyes and potentially put someone that wasn't even diabetic, now they have gestational diabetes and could develop some form of retinopathy?
Most of the people that develop diabetes when they're pregnant, they're almost like a type 1 diabetic, or like an early type 2 diabetic that that behaves more like a type 1, but just from pills. A true gestational diabetic very seldom develop retinopathy by itself. The problem is that a lot of these gestational diabetics will, they could have been, pre-diabetic. Now they are gestational diabetic, and now they fully become full diabetic. And
Okay.
so a lot, it's just a precursor. But it takes, several years to actually develop retinopathy in the eye. So if they are having a child and they see diabetes in the eye, most likely they're probably already had, diabetes. It just doesn't pop up just because this happened. But what we tell our type 1 diabetics or our type 2 diabetics who are not on insulin and they're still at the childbirth, if they're planning for their family, we want to make sure in that first trimester they come in, get their eyes checked. We follow them very closely. I look at diabetes as like a journey. I want to be on this journey with you. And as long as you are on this journey, I'll be able to monitor you and treat you so you can still have a good outcome and still enjoy your family when all this is done. It was a shame, I'm just going to give you a history lesson here.
Sure.
Before insulin was discovered, let's say in 21 or 1922 by Eli Lilly, the average age of a type 1 diabetic around 18 or so living was about 2.5 years. The treatment before that time was really surgery. They were removing people pituitaries. And for women, the recommendation for a pregnant woman back then was to abort their fetus.
Oh, wow.
Because they didn't know how to take care of the large babies and keep mom healthy. Now, because we have insulin, we're able to have a healthier life, but now we have all the complications. We have larger babies, we call that macrosomia. That's just because the baby is absorbing so much more of the sugar, and now we're starting to see all the complications. There was no complications back in 21 and 22. People just died. They just went into a coma, right? But now that they're living so much longer with metformin and insulin and all the other medications that we have, now you're starting to see the long chronic conditions. And that's what meant that, back then there was no kidney problems, no eye problems, no heart problems. They didn't have it long enough. So that kind of is very similar to when, you get gestational diabetes, because it happens during that small period of time. You don't develop any retinopathy. But if you continue down that path line and your sugars don't go down after surgery, then obviously over time, there's a possibility that you can develop retinopathy if you don't control your sugars.
Wow. Okay. So if you're just joining us again, we are here with Dr. Joe Coney. He is an ophthalmologist. He is an eye surgeon, and he's a diabetic specialist. And we're talking about diabetic retinopathy and all of the changes that just uncontrolled or poorly controlled diabetes or diabetes in general can have on your vision. And so we want to thank our friends over at Genentech for helping us put this on. Another question. Okay. So we got a question here from Talitha Harrison. She is saying, how can you deal with being insulin resistant while being pre-diabetic?
Talitha, I am a retina surgeon, and I'm going to leave these sort of things to my colleagues who actually deal with all these complicated. I don't treat retinopathy. Obviously, I treat the end stage organ, and there's all these little nuances that they're trying to address. But I think that there are some people that have antibodies, and that the insulin just doesn't work as well, and that's a little bit higher than my pay grade. And I think that's a great question, because doctors, they sometimes treat patients aggressively, but the sugars don't come down. And the question is like, well, why is your A1C is still 12 and 14, and your doctor increased your insulin and your medications, and you're not getting better? So I think there's a subset of people that don't respond is because I think they have these antibodies where the insulin just doesn't work as well.
Okay. So I will encourage you. I love the questions that are coming in. But again, Dr. Coney is an ophthalmologist, so we're going to focus mainly on the eyes. And so he's talking about diabetes and its relationship to the eyes. But we're going to kind of, so we have to talk about diabetes because we're talking about diabetic retinopathy. but he's talking about the eyes and the impact it has on the eyes. So he's going to give he's going to do what he needs to do in terms of trying to answer your questions. But when we start getting really deep into the diabetic questions, those are questions more kind of suited for people that specialize specifically in diabetes. All right, so we're just going to kind of put that disclaimer out there because we don't want to, Dr. Coney can come bombarded with questions about insulin and A1C and all that other stuff.
It's okay, Dean. Listen, we'll filter them out. We will have the discussion, and I'm loving the questions, but I'll do the best that I can. But that's okay. I think the most important thing is that we find those answers out. So you will have people come out. Those are questions that you can store in your database and make sure those questions get answered. That's good stuff.
Absolutely, and I appreciate the fact that people are really, really excited about this topic. So, all right. So here's a question: how often should diabetics have an eye exam? Is it annual, or should they have it more often?
So at the diagnosis, a type 2 diabetic really should have an exam at the time after they're being diagnosed with diabetes, because the problem is that, again, we don't know how long someone's had diabetes. And unfortunately, although the ADA recommendation is that, such, and then annually thereafter, if there's no problems, 50% of the people still don't come in when they should, even if they're told to go see an eye exam, to have an eye exam, because they're not having problems. There are no symptoms. There's no pain. It's amazing, man. I'll see people for a cornea abrasion because they're in pain. They call me like I need to be seen right now. They can lose their vision. It'll take them to come in 3 to 4 months. Oh, doc, I thought it would go away. So if a patient doesn't have pain or irritation or redness, we haven't made eyes a priority where that should be checked right away. And again, the problem is that, in racial, ethnic groups, diabetes is 2 to 3 times more common. So the likelihood of people losing vision and going blind over time is too fast. And by the time they come to see me, those people have already lost vision. And once you lose vision, I can't always get it back. But if I can see something in the eye, even on an exam before it bothers you, 90%, really 94% of the time, I can actually stabilize your vision. Those are powerful numbers, which we don't see across medicine.
Absolutely. So I heard a rumor, and you can either verify or deny. So this is a rumor that I heard, that you, based on eye exams, you can even determine if they don't even know they're pre-diabetic or diabetic, that you can help them do your eye exam, say, hey, you might want to go get your blood sugar checked. Is that true?
So oftentimes I am the first one to diagnose diabetes. People come in because they have blur vision, and it could just be difficult in the reading. It could be just having a hard time reading the car signs, or the signs when they're driving, or the car lights, that they get the glare around it. Because when you have diabetes, there's a few things that can happen. First of all, if you have diabetes, it also puts you at risk for glaucoma. Okay. It also puts you at risk for increased cataracts, in addition to retinopathy. So all these things could be getting worse. And we already know that glaucoma is the number one cause of blindness in blacks. Okay. So there's a lot of things on what I diagnose which people are not aware of. But when it comes back to diabetes, oftentimes we are the first ones. We are the ones send them to the medical doctor, and they get diagnosed at that time because the A1C is checked. The problem is that a lot of our people don't have physicians, and they use the emergency room as their primary care doc. So they'll go in for an acute problem that'll get addressed, but they don't have any long-term relationships with a physician, so that routine maintenance is not done. So by the time they come into their doctors, they've already got long-term problems.
Right. So I'm going to say what Dr. Coney can say. You can't use the emergency room as your primary care physician. All right, just folks, got to stop doing that. Okay.
Say 100.
It's just, I'll say it for you, Doc. I'll say it for you. You can't use the emergency room. You have to establish a relationship. So now,
I do want to say something here, because this is important. What we don't do very well, physicians, is that we don't really talk to our communities very well.
Okay.
And so the good thing about what you have a great platform, because you can talk about things and you can dig into things, which I can address a little bit. People come in, but you can get in there and you can help people have that conversation.
Yeah.
And what I'm talking about is social determinants of health. And oftentimes the reason why we don't see Black people early enough is because they have a lot going on. Oftentimes, if you look at all the stats, we have the lowest median income in the country. We have the least amount of education in the country. We have, we're at the highest of everything, right? So when you add all these things in and you throw in the trust and the mistrust and the lack of communication and the lack of doctors that look like you, where you feel comfortable in actually talking to, people just don't feel comfortable coming in and having that discussion with a doctor. When they're not having a problem. End of the day, we all want great care. End of the day, doc, take the pain away, and we're happy. But when we don't have problems, because there's been so many issues that's going on, and there's direct correlations too. When you have multiple people in the family, you're the primary caregiver. You may not have time to go in and get yourself checked out. Also, it also shows that the more family you have in a house or more mouths you got to feed, that could be a precursor to homelessness for some people.
Yeah.
And that's hard, real talk, because people are struggling and say that they don't have the money for the co-pays. They don't have the insurance or the lack insurance or the eye insurance. And so they may want these things, they just don't have it. They may not have the transportation. A lot of times we may be down to one car or no car. And if you have diabetes and you've already lost vision, guess what? You can't drive. You are dependent on someone else.
Yeah.
That clinic, which is maybe only 20 minutes away, it can feel like an hour away if you got to take a public transportation. So a lot of these things, may not be any fault of the person, except for they just trying to live. And what I tell people, if you're at home and you're taking care of your loved ones, if you want to be a blessing to other people, start being a blessing to yourself. Because if you lose your vision, you cannot do the things that you want to do for other people, because you can't provide the way that you need to, because you're not doing well yourself.
Yeah. No, that was very well stated, because you're absolutely right in terms of that. That's a phrase that gets repeated a lot: social determinants of health. But it is very, very true, and it does impact our abilities to be able to go see. So yeah, we can sit here and bang this drum about, you need to go see this doctor, you need to go see the dentist, you need to go see this doctor, that doctor, that doctor. But every time we say we need to go see that doctor, that means I might have to take my time off from work. Work that is vital to me paying my rent and putting food on the table. So sometimes people have to make a very hard choice.
And the last part is that when people develop diabetes, particularly diabetic macular edema, which is leaking fluid in the back of the eyes, we know that they are seeing a doctor at least 24 times a year compared to those individuals that did not have diabetic macular edema. So they're spending times in the hospital, in inpatient clinics, outpatient clinics, way more than other people. And if you're working, man, you just have a hard time taking that time off to see all these doctors. You got the kidney doctor, you got the foot doctor, you got your endocrinologist, you got the internal medicine doctor. Now you got an ophthalmologist, right? I mean, you got a lot of people to see.
You may have a cardiologist because you may have PAD as a result.
That's right.
So, all right. So you mentioned macular edema a couple of times. Help us understand what that is and how it relates to diabetic retinopathy.
So diabetic macular edema is just a complication of diabetic retinopathy. So not everyone that have retinopathy is going to develop diabetic edema, but everyone that has diabetic edema has diabetic retinopathy. Gotcha. And it is the leading cause of decrease in vision. So that's why I talk about it, because it is the number one cause and why people lose vision from diabetes. And all it is that once the diabetes, get more progressed and it starts to damage the blood vessels, they become leaky. And basically, I tell people it's kind of like putting ice in a glass. If you put ice in a glass, you come back in about 5 minutes, there's a little condensation on the side of the glass. Well, you put that on your table, you come back in 15 minutes, now you got a puddle of water on the table. Well, that's diabetic edema. It's a slow leakage of the fluid that really should stay in the vessels that slowly leak out. And this leakage then puddles in the middle of the eye, which is called the fovea or the macula. The fovea is just the center of the macula. But that's responsible for your very strict vision. So you needed to read, you need to drive, but once you lose that vision, your vision become blurred, you become splotchy, the contrast is not good, you start missing things. And then as it progresses, sometimes it becomes irreversible, because it's kind of like, it's kind of like water law. And so too much water in the retina over time just destroys the back of the eye, where people start to lose their vision.
Okay, so it's the kind of like that when we're talking about earlier, we were talking about the stages of a diabetic retinopathy. This might be like stage 5, like at the end. No,
actually not. So diabetic macular edema can occur at any stage.
Oh wow, okay.
It occurs the mild, the mild, the moderate, severe, the proliferative disease. Now, as the disease progresses, it's much more common.
Okay.
But diabetic edema can occur at any stage. And that's the reason why it's so important to get that annual exam, because if we pick up that swelling, we could reverse that swelling before it becomes chronic, and we can pretty much decrease the rate of vision loss with our therapies.
Okay, man, it's so
again, there is no reason why anyone in our community need to go blind from diabetes. Hey, come see me, take that journey with me. I'll keep you seeing.
Now, Doc, we just talked about social determinants of health. I think I have to come to Cleveland to see you. So and I don't know if you've seen these plane ticket prices. They're not going down. They're not going down at all. But in all seriousness, I think we're talking about with. I would say this as the kind of the layperson in this conversation. What I've learned in this Healthy Vision Month is that people treat vision the same way like they treat the dentist. They don't go to see the ophthalmologist until there's a problem. People, they may or may not go see the dentist, but then when there's a problem and you got a toothache, everything stops, right? But when your vision starts going, I need to go see it. And by then, it sounds like what you're saying is, you should have been seeing me before, because then maybe I could have caught this earlier, and we could have either slowed or stopped this trending altogether. But now that it could get to a point to where you're like, hey, I'm just going to try to, put a Band-Aid on it, because it's really progressed to the point, of no return.
That's absolutely correct. Well summarized. Good job.
Okay. All right. So, folks, and I know, and it's tough because we've talked about, especially if you're diabetic, right? So diabetics, we're talking about inflammation, right? We're talking about impact on multiple organs, including the eyes, the kidneys, because diabetes is the number one cause of chronic kidney disease, and we know then that gets you on the dialysis. So there's.
Let me tell you. Listen, if you have kidney problems, you already have eye problems. Okay. I know a lot of times people come in and I see the change in their eyes. They don't have any other problems, but I know microscopically they already have problems. They just haven't been diagnosed. They can't be seen. So when people say the eyes are the keys to the soul, it really is the key to their soul. The greatest thing about what I do, again, I can look in and I can look at changes. What I do is that I take a photograph. And I'll put the photograph up in the room, and I'll let the patient look into their eyes. They sit back, and it's a powerful moment because they didn't realize they had a problem. The biggest impact is always on my strong guys, right? They're out there playing basketball, they're running, they're boxing. I mean, they're having a great time. And when you show them their eyes, they sit back. Some of them, get a little emotional. But I think that's the time that I connect the most, because I give them a glimpse of an organ that they didn't know they had a problem with. And then we talk about what this could look like going forward. And I also try to help steer that conversation on what they should be talking to their physicians about. That's the first time I get people to stop smoking. First time I get people to actually stop drinking. First time I get people to let them that put health at the number one priority than other things in life. Because, making those changes, you had a guy that, earlier, he mentioned that he lost weight. That was a substantial accomplishment for that gentleman. And he did so well, he was off his medication, right? I mean, so just by changing the small things in life, you get a big punch, later on. It's kind of like a savings account. You got to keep putting that in order for you to get the rewards later on.
Right. And it's funny. I started reading. I do all these things again in a self-help mode, and so I started reading this book. It's called Atomic Habits. Right. So I'm not, I think the last name of the guy is Clear. And we talked about changing habits and developing habits versus setting goals, right? Because goals are limiting, right? I achieve the goal, boom, you stop. When you change your habits, that goal becomes part of your life, right? And so we're talking about doing something that's long-term. So the habits that we develop early on could be some very bad habits. Drinking a lot of sugary sodas, eating a lot of sugary foods, eating a lot of foods with a lot of preservatives. Some of that is predestined by social determinants of health, not having, living in food deserts, having only those convenience stores, and we could talk about that too. But those are the habits that we develop over time, drinking, and so that helps. In that habit, then we start getting the pre-diabetic and to diabetic. Now we've got to change our habits, right? Now the goal can't be, I'm lowering, I got to get my A1C down at this point. That is a result of you changing your habits. And so we've got to really think about it in a different way. We change our habits to get to the results, not change our behaviors to engender certain results, because that's only limiting, right? And that's only can be sustained over a short period of time. When we change our habits, eating, exercise. Doc, you got to hit him with the ABCDE again. Got to hit him with one more time.
So ABC, so your A1C less than 7, your blood pressure less than 140/80, watching your cholesterol, your diet, and your exercise. Those are the most important thing. And then I'll throw in the S, which is smoking. So those are the essentials that we need to do to control the diabetes, to prevent worsening diabetes, and particularly worsening your level of retinopathy.
Roy, he's put in his formula for how he lost weight. He said what's been helpful for him, and this is not, we're not going to put endorsement, but he says what's helpful for him was intermittent fasting, diet, and staying active. So that's part of one of those ABCDEs that we've been talking about in terms of just making sure your health has got to be a priority, right? And so Dr. Coney is talking about going to see the doctor, going to see your ophthalmologist once a year. Right? Think about how many days are in a year, how many hours are in a day, how much time that you actually get to see Dr. Coney. The rest of that time, you are driving your health outcomes, right? By what you put in your body, by how often you exercise, how much you exercise, everything that you do every single day between the last time you see Dr. Coney and the next time you see Dr. Coney is going to determine how that next appointment is going to be. It's not Dr. Coney. Dr. Coney's going to give you some advice. He's going to give you an exam, and he's going to tell you what's happening with you. But everything that happens between those appointments is driven by you. And so we've got to understand that we have to take control of our health outcomes by making it a priority every day. Just like going to work, you should be thinking about your health.
Hey, Ellis, we've been talking a little bit about social determinants of health, and people may not really know what that is. But social determinant of health is, to put it simple, it's kind of where you live, you play, you work, you age. It's the things that affect your environment. Part of that environment is having a healthy environment. And sometimes the environment that we live in may not be very safe. And because it's not a safe environment, we don't get out and walk. We become more sedentary. And for those, and I know that not everyone has a park close by or a mall close by, but those things, those are other avenues that you can do. You can find someplace safe just to walk. YMCAs are important. So you don't necessarily have to walk in your neighborhood if you really don't feel safe.
Yeah, and that's a great point, because I don't want to be dismissive of challenge that folks might be experiencing in terms of their ability to exercise. And so and then we've got some programming here on blackdoctor.org, right? So we've got exercise programs 5 days a week, and sometimes in the evening. Every Monday, Wednesday, Friday, we got Elena and Get Fit, so you can put your computer up and work out at home with Elena for 30 minutes. Tuesday and Thursday, we got Fitness Knob. You can put in your computer and work out with her. And then in the evenings, we've got Strength of Seduction on Thursday night. And that is with you and your wife or your spouse or your partner. And y'all could do it together. And that's more of a romantic kind of relationship focused fitness exercise. And now we've got a show on Wednesday evening as well. So you can work out at home too here at blackdoctor.org, because we're trying to help you get healthy any way we can. So if you're watching us now and you say, you know what, it's too dangerous to go outside, you can stay home and we can get that exercise in at home here with Black Doctor.
One-stop shop. I love it.
Yeah, we try to do everything here. So, and that's really, the impetus to getting to this discussion as we're wrapping up here with Dr. Coney. in our first of our 6-part series on eye health and the impact that diabetes can have on your eye health. What we're talking about really here is the overall. And overall, we can't just, when we go to our primary care physician, that's a kind of a overall checkup, but then there's specific things we have to get done as well. We talked about dental health. If you get to a certain age, you need to get that prostate exam. You need to get to colonoscopy. There's a lot of things that need to get done. Managed care, Obamacare, whatever label you want to put on it, does cover screenings, because they'd rather pay for screenings than pay for surgery, right? And so screenings are included in many of those products. And so we've talked about that here as well. I interviewed an insurance specialist, and we talked about open enrollment and signing up, and why it's important to sign up for open enrollment and finding a plan that fits you. And so all of these things are really, really important in terms of our overall health. So I love the ABCDs. I'm going to use that again, so I'm going to give you credit for it every time I use it. When I'm starring at parties and I say, hey, here, as Ellis, I'm like, well, I'm going to give you the ABCDE and what you need to be doing if you're diabetic. And I said, this is courtesy of Dr. Coney, right? So I'm going to give you credit every time. I'm not going to steal your thunder.
Well, Ellis, listen, again, back to social determinants. One of those determinants, again, is health literacy, right? And so, and as well as communication, I think it goes hand in hand. You have to be able to communicate with your patients and give them something they can understand. So I think end of the day, the problem that physicians and patients have is that a lot of times physicians, who's the best advocate for patients, at least we think we are, we sometimes talk over our patients. We tell them what to do, what they need to do, and all these sort of things. But if a patient leaves our office and don't understand what is going on, what the doctor actually meant by all these crazy words that we use, didn't give them an agenda with to follow, a regimen, they're less likely to be compliant. They're less likely to take their medication. They're less likely to keep their follow-ups. And so we have to be able to understand who we're talking to. If Mrs. Johnson, if you don't speak in Mrs. Johnson's native language, Mrs. Johnson don't think you're a good doctor, and you could have done everything correct. So it's not about what the doctor thinks, it's really what the patient feels. And we need to refocus the way that we look at that person that looks across from us. We need to deal with our own implicit bias and understand what their determinants are, what they may be nervous about, what they may be more concerned about, and then make it like a journey and say, Mrs. Johnson, listen, we got some problems. This is what we're going to do. This is going to be our journey, and this is what we're going to have to do in order for you to get better. And, customize that medicine for Mrs. Johnson. And I think that's really the best way to break down the barriers of trust and mistrust and communication and the things that keep, most of our Black, patients, out of our offices.
Well, you got an amen from Cassandra. You're absolutely correct. And so I think we're going to end on that note, because I don't think I can say anything better than wrapping it up right there. Thank you. I want to say thank you to Dr. Coney. Thank you to our partners at Genentech for having this discussion and being part of the 6-part discussion here on your eye health. We're going to have Dr. Coney back. We may have some special friends to come in and visit us. So it won't always just be me and Dr. Coney, but we're going to really talk about eye health and really encourage everyone. And the purpose of this whole thing is, particularly for our diabetics, you've got to make a visit to the ophthalmologist part of your routine. If it's not part of your routine, you've got to make it part of your routine. If you're pre-diabetic, you need to do whatever you need to do to get out of that pre-diabetic stage. That means follow those ABCDEs that Dr. Coney has said multiple times during this program. We've got to do those things to lower our blood sugar to get us out of that diabetic realm. Number 3, we cannot discount the social determinants of health, but we cannot let that be an excuse as to why we are unhealthy, right? There are workarounds for everything in our lives, and we're doing whatever we can here at Black Doctor, and there's ways to work around to get the things that you need to get done. Some of them may be more challenging, but what's more important than your health, right? I know your jobs are important, but there's nothing more important than your health and being healthy. And just losing your vision can have more of an impact on your ability to work than anything else that's going on in your life. And so we got to make sure that we protect our most precious asset, and that is our health. And so I'm sure there's some other points that we've made today that I've missed. Dr. Coney, hey, wrap it up for us. You've been a rock star tonight, so we're gonna let you close us out.
Well, Dean, this has been a really good segment. I think the most important thing you've already hit on. The most important thing, as far as I'm concerned, is making sure that we make eyes a priority. And the way we make eyes a priority is that you go in and you get your eyes examined, have that discussion with your doctor, ask them about the health of your eyes, help them to make the right staging so they can, if you need therapy, institute therapy early, because early therapy means delay of vision. That's it.
Look, that's a mic drop on that. So if you have a friend that needs this information, they weren't able to watch tonight, make sure you tag your friend or share this on your page. Tag them, share it, like, comment, and we will get back to you. So we'll see Dr. Coney next month. We'll come back for part 2 of our series on eye health. And we thank you for joining us tonight, and we will see you all next time.